evening, everyone, to another session of Stroke Support India. And we have many people here, I would say today, almost kind of a global representation across many countries. So thank you very much for everyone for joining in. We have Professor Bruce Hetzler. He has been with us a couple of times before on two presentations, and himself is stroke affected and doing wonderful job in raising stroke awareness and awareness of related issues. Today we are going to talk about aspects covering language and brain, specifically the reference to aphasia, which is a frequent occurrence of stroke. I was reading somewhere that about 30% of the stroke affected will probably have some kind of speech deficits, most of which fall under the general category of aphasia. So Professor Bruce will elaborate upon that. And just to give a short introduction to Professor Bruce, he was a professor of psychology and neuroscience at Appleton, Lawrence University, where he suffered a stroke about 10 years ago at the age of 62. Serious stroke. He was in coma for about a week, I think, and then intensive care, stays in nursing home. But he returned to teaching, and he taught for 8 more years before he retired in 2019. And prior to stroke also, with the talking, it was his passion. Magic was his passion. He's again attempting that, starting that, along with the mission of raising stroke awareness and inspiring stroke warriors. So thank you very much, Professor Bruce, for joining in. Thanks again, everyone, for joining in. And Dr. Bruce, Professor Bruce, you can start your presentation today. Now, over to you. I'll be just mute myself and I'll be in the background. Over to you, Professor Bruce.
Okay, thank you very much. I'm going to share my screen now and put the PowerPoint on. Here we go. There, I'll talk about language and the brain, because June is Aphasia Awareness Month. And when we're talking about the effects of brain damage, be it a traumatic brain injury or a stroke, it can often affect our linguistic ability. So, these are the topics that I will cover: Broca's aphasia, Wernicke's aphasia, conduction aphasia, global aphasia, Alexia with Agraphia, Alexia without Agraphia, Prosody, Phonagnosia, Prosopagnosia, the Aprosodias, and then treatment for Broca's aphasia after stroke. There'll be a lot of material here, so I'll try to get it done within 3 hours or so. Just kidding. So, we can talk about cerebrovascular accident. That's brain damage caused by occlusion or rupture of a blood vessel in the brain. And aphasia is difficulty in producing or comprehending speech, not produced by deafness or motor deficits. So aphasia is an impairment of language that can affect both the production and comprehension of speech and impair a person's ability to read and or write. Aphasia is always caused by an injury to the brain, and stroke is the most common cause of brain injury that leads to aphasia. About 25 to 40% of people with the stroke acquire aphasia, although head trauma, infections, tumors can also cause aphasia. Aphasia can be mild and only affect a single aspect of language, or it can be severe, so severe that it's very difficult to communicate with the patient. Most commonly, multiple aspects of communication are impaired. Some people can recover from aphasia But if they have it longer than 2 or 3 months, it is very difficult, though not impossible, to recover. Now, let's say a little bit about the structure of your brain. What is shown on the right-hand side of this is a coronal section of the brain. And you can see the difference between white matter and gray matter. The gray matter is the outer portion, and that's made up mainly of cell bodies, neuronal cell bodies. The white matter on the inside is axon pathways, and the white is caused by the myelin sheath around the axon. A main component of myelin is cholesterol, which looks white. You can also see the outer portion of the brain, and if you look at the upper right-hand portion of the figure, you see a bump on the brain. It's called a gyrus. Every gyrus in the brain has a name. A small groove in the brain is called a sulcus. You can see that in the upper left-hand part. A larger groove in the brain is called a fissure. So we'll begin by talking about Broca's aphasia. And that's caused by damage to what is called Broca's area. Obviously, that's named after Broca, who was the person who discovered this. Whoop. In the upper left-hand portion, you see a picture of Paul Broca. And his first case, if you see in the lower left-hand corner, was a patient he called Tan, because Tan was the only word this patient could say. Tan died in 1861, and that allowed Broca to examine his brain. And here you see a number of pictures of Tan's brain. And you can see the hole in various pictures that caused Tan's aphasia, his inability to talk. Now this shows the speech areas. You're looking at the left side of the brain, and in yellow, you have Broca's area. That's the part of the brain that was destroyed in Broca's patient, Tan. That area is involved in the production of speech. The lower right, in sort of a pink, you see Wernicke's area. That was discovered in 1874 by Carl Wernicke. And that is involved in the understanding of speech. Whereas Broca's area is in the frontal lobe, Wernicke's area is in the temporal lobe. And this shows the left hemisphere of the brain, and you can see the lobes of the brain. Now, normally they're not color-coded in the human brain, but you can see in blue, this is the left hemisphere again. In blue is the frontal lobe, and that's involved in control of movement. The dark blue portion in this figure is your primary motor cortex. That contains the cells that control movement of the body. The left hemisphere controls movement of the right side of the body. And you may not be able to see this arrow that I'm moving around here, but just anterior to the dark blue area is Broca's area. It's just in front of the portion of the primary motor cortex that controls the movement of the lower half of the face. That is the mouth region, which is what you obviously need to talk. Behind the frontal lobe, in sort of an orange, is the parietal lobe that controls body senses. You feel something when cells in the parietal lobe become active. In green is the temporal lobe. That is where you hear. You see a dark green area. That's your primary auditory cortex. You hear something when the information arrives there. Just posterior to that is Wernicke's area. That is where you understand language. At the back of the brain is the occipital lobe. In the very most posterior part is where your primary visual cortex is. That's where you see something. You don't see anything until the information activates neurons here in the occipital lobe. So, damage to Broca's area. Does this cause language problems because the facial muscles are paralyzed? No, it does not, because the facial muscles, the lower half of the face, has muscles that are controlled by both sides of the brain. So Broca's aphasia does not result from paralysis of the facial muscles. And by the way, in 1865, Broca reported that damage in the left hemisphere caused language problems, but right hemisphere damage does not. That is true for expressive speech, but as we will see later on, the right hemisphere does have some involvement in certain aspects of speech. So what are the symptoms of Broca's aphasia? It is a non-fluent aphasia. The speech is very telegraphic. That is, an early telegraph would just transmit the important words. It would leave out interconnecting words like if, and, the, but, and so on. And a person's speech with Broca's aphasia leaves out those small words also. It's almost impossible for someone with Broca's aphasia to say no ifs, ands, or buts. Those little words they just can't say anymore. They can often just say single words. For example, there was one case of a minister's wife who had a stroke and could only say two words, hello and damn it. That's all she could say. So someone with Broca's aphasia has severely reduced speech, a very limited vocabulary, and their talk is very clumsy. They also have problems writing, although they can read and understand well. Does anyone know who that is? That is Randy Travis, a country western singer. Why do I show you that picture? Randy Travis had a stroke in 2013. That left him unable to speak or move without assistance. He spent 2.5 years in daily therapy in order to regain the ability to do basic tasks. Although Randy Travis has severe aphasia, he can still sing. Why is that? That is because singing is controlled by the right hemisphere, while speech is controlled by the left hemisphere. So we will move on now to Wernicke's aphasia, first described by Carl Wernicke in 1874. In contrast to Broca's aphasia, Wernicke's aphasia is a fluent aphasia. People talk with normal cadence, with a normal rhythm. But interestingly, what they say doesn't make sense. So they will pause normally, have a normal cadence or a normal prosody, which is the melody of speech, but what they say is meaningless, much like the speech of a politician. That's a joke. In Wernicke's aphasia, the person has problems reading and writing. They have an inability to grasp the meaning of words. And they will often add irrelevant words when they're talking. So what part of the brain is damaged in Wernicke's aphasia? The middle and posterior portion of the superior temporal gyrus of the left hemisphere. Now that's a lot of words to describe it. I mentioned every gyrus has a name, and here's the left hemisphere of the brain. And down near the bottom, in the temporal lobe, you have the superior temporal gyrus. Below that is the middle temporal gyrus, and below that is the inferior temporal gyrus. So Wernicke's area is here towards the posterior part of the superior temporal gyrus. I hope everyone followed that. Okay. Again, here you see Wernicke's area, the posterior part of the superior temporal gyrus, and up here you have Broca's area in the inferior anterior part of the frontal lobe. Now, this view of the left diagram shows what goes on in your brain when you're speaking a word that you hear. You hear the word in your left primary auditory cortex, here in the temporal lobe, talking about the lower portion of the figure here, and then there's an arrow going from that to Wernicke's area. That's where you understand it. And from Wernicke's area, information is transmitted over the Arcuate Fasciculus, that's an axon pathway, to Broca's area in the frontal lobe. And then Broca's area tells your primary motor cortex to talk, and you talk. And here's what happens if you are speaking a written word. You see that word in your primary visual cortex at the very back of your brain. That information is sent to the angular gyrus, and the angular gyrus is part of the brain that converts visual information to auditory information, and vice versa, that is auditory information to visual information. In this case, if you read a written word, the visual image arrives in your primary visual cortex, then has to be converted by the Angular Gyrus into an auditory form before you can understand it. That auditory form is then transmitted to Wernicke's area, and Wernicke's area sends it to Broca's area, which controls your primary motor cortex, and you talk. So let's talk about the Arcuate Fasciculus. That's an axon pathway that interconnects Broca's area and Wernicke's area. If it's damaged, you get a problem called conduction aphasia. In conduction aphasia, you can understand speech because Wernicke's area is intact. You have fluent speech, but it is very poor for you to repeat things. And again, it's caused by damage to the Arcuate Fasciculus. These are CAT scan images that show the location of damage to the Arcuate Fasciculus that would produce conduction aphasia. It's in the left hemisphere of the brain that the damage occurs. Again, that's on the right side of this image. And this again shows Wernicke's area, the Angular Gyrus, and the Arcuate Fasciculus going from Wernicke's area to the frontal lobe to Broca's area. Now, a study was done in 2005 that used magnetic resonance imaging, a rather complicated use of the MRI, and found that there are actually two parallel pathways in the Arcuate Fasciculus that are responsible for different aspects of speech. The first one is the classical Arcuate Fasciculus. It's a deeper pathway. It's a long, direct pathway, and that's the pathway that allows you to automatically repeat what you hear. You hear it, and you can say it. And then there is a second pathway that is more superficial, that is more towards the surface of the brain, that has two segments. One goes from Wernicke's area to the inferior parietal lobe, and then the second part goes from the inferior parietal lobe to Broca's area. This pathway is used to understand what you're saying. Damage to this pathway spares the ability to repeat what you hear, but it impairs your ability to understand what you hear. And this next slide shows what they found. You can see the two portions of the superficial pathway here. Again, going from Wernicke's area, shown in the lower right, to the parietal lobe. The second, the anterior segment, goes from the parietal lobe to Broca's area. Now we'll talk about global aphasia. This is caused by a stroke of some sort that destroys what's called the entire perisylvian region of the left hemisphere. The sylvian fissure is a large fissure in each hemisphere. And when the blood supply to that region is destroyed, that destroys both Broca's and Wernicke's area. Since Broca's area is destroyed, the person can't talk. Since Wernicke's area is destroyed, the person cannot understand speech. And again, it's caused by a stroke or blockage of the middle cerebral artery of the left hemisphere. If you look at the upper figure here, now this is actually the right hemisphere, but the same thing would occur in the left hemisphere. The middle cerebral artery is shown in red, and there is this sylvian or lateral fissure, and when that whole artery is blocked or ruptures, then you eliminate all the blood supply to the areas above and below it. So you're destroying Broca's area and Wernicke's area. Okay, this summarizes what we've talked about. At the front, you see Broca's area, and the temporal lobe is Wernicke's area. And at the back, you have the Angular Gyrus. Joseph Desjardins in 1891 dealt with a patient with a problem in the Angular Gyrus, and that produced Alexia with Agraphia, an inability to read and an inability to write. Since the Angular Gyrus was damaged, this patient could not convert visual to auditory information, so he could not read, and he could not convert auditory to visual information, so he could not write. Later in 1892, Desjardins reported what he called pure Alexia, or Alexia without Agraphia. This person could write but could not read. He was blind in his right visual field. He could see in his left visual field but could not read anything there. There were two lesions, one in the visual cortex of the occipital lobe of the left hemisphere, and another one, the splenium of the corpus callosum. The corpus callosum is a band of fibers that interconnects the left and right hemisphere. If you look down at the bottom, you see a diagram showing the two lesions. So at the lower left-hand side, see the damage to the left occipital lobe, and that's where visual information from the right visual field would arrive. Since this was completely destroyed, the person was blind in his right visual field. Then higher, you see damage to the splenium, that is the back of the corpus callosum. That transmits information from one side of the brain to the other. So visual information arriving in the right visual cortex could no longer cross over the corpus callosum to get to Wernicke's area. And Wernicke's area is located only in the left hemisphere, so the person could not understand anything in the left visual field. And this shows a diagram of the corpus callosum. The front of the corpus callosum is called the genu, the middle part, the body, and the posterior part, the splenium. It's the splenium that sends visual information from one hemisphere to the other. And that was damaged in that patient. We will move on to the right hemisphere. Some people with localized brain damage in the right hemisphere have difficulty recognizing voices. This is called Phonagnosia. All cases of acquired Phonagnosia show damage in the right hemisphere. So your right hemisphere allows you to recognize someone's voice. The damage is caused by damaging the parietal lobe or the anterior superior cortex. This is the left hemisphere, if you look on the left side here, but the same thing would apply in the right hemisphere. So because phonagnosia would be caused by damage in the parietal lobe or the upper part here of the temporal lobe. What about the ability to recognize someone's face? Damage to a structure in the right hemisphere eliminates that. This problem is called prosopagnosia. This is a neurological condition characterized by an inability to recognize the faces of familiar people. The neurologist Oliver Sacks published a book called The Man Who Mistook His Wife for a Hat. That's the title of the book, but also the title of one of the chapters. And he dealt with a patient who could not recognize other people's faces. In particular, he could not recognize his wife's face. And since he could not recognize it, he would reach over and grab her by the hair, thinking that she was a hat, and try to lift it up. But when that caused pain, she yelled out. He recognized that it was her by understanding her voice. So prosopagnosia results from a problem in the right fusiform gyrus. This is on the underside of the brain and is involved in perception of the face. Prosopagnosia can result from a stroke, traumatic brain injury, or neurodegenerative diseases like Alzheimer's disease. This shows the underside of the brain, and the right side of the brain is shown on the left side of the figure. And in pink here is the fusiform gyrus. So damage to the blue part here causes prosopagnosia. The right hemisphere is also involved in prosody. Prosody is the melody of speech. We use changes in intonation or melody to convey meaning. For example, we'll take the simple declarative statement, I am going to the movies. I can alter that to make it a question. I am going to the movies? Okay, the meaning changes because of a change in the prosody. Or I could express anger. I am going to the movies. That again is a change in prosody. And actually, I am going to the movies tomorrow to see Top Gun. And I'm happy with that. Anyway. So the right hemisphere is involved in prosody, the rhythmic, emphatic, and melodic aspects of speech. Prosody is normal in people with Wernicke's aphasia, but destroyed in Broca's aphasia. Ross, in 1981, described the Aprosodias. These are problems in prosody caused by stroke. Now this shows recordings from the brain in functional MRI images. Functional MRI shows blood flow changes. And as you can see here, when people listen to normal speech, the left hemisphere was active. But when they only heard the prosodic elements, the right hemisphere was active. So Ross described the Aprosodiums. He examined 10 right-handed patients with a stroke of the right hemisphere and disorders of effective language. Observations were made about these patients' spontaneous prosody, the ability to repeat prosody, prosodic comprehension and comprehension of emotional gesturing. He called one group of patients as those having motor aprosodia. They had the stroke in the right inferior frontal lobe. Prosodic comprehension and comprehension of gesturing were intact. They could not repeat that, and they couldn't spontaneously alter their prosody. And this occurred from damage in the right hemisphere, which is the mirror image of damage to Broca's area in the left hemisphere. Then sensory aprosodia developed a problem, a stroke, in the right posterior superior temporal lobe and posterior inferior parietal lobe. These people had good spontaneous prosody and gesturing, but poor repetition and poor prosodic comprehension. So this was the prosodic counterpart of Wernicke's aphasia in the left hemisphere. Again, this is the right hemisphere, and you get sensory aprosodia, the problems in the temporal lobe, and motor aprosodia, problems in the frontal lobe. What about recovery from aphasia? Recovery from aphasia depends on neuroplasticity, the foundation of all learning. Stroke and aphasia survivors have learned about plasticity and recovery the hard way. Experience-dependent neuroplasticity. Recovery from aphasia is prompted by speech therapy, and there are three main approaches for recovery of Broca's aphasia. One is called constraint-induced speech therapy, another melodic intonation therapy, and finally, vocal music listening. Constraint-induced speech therapy involves intense practice over a few days, what's called massed practice, and the patients practice speech acts with which they have difficulty. They're encouraged to try to talk over and over and over again for 4 or 5 hours a day. They are encouraged not to use their arms or make drawings, but they had to use their mouth and talk. And they were encouraged more and more to stop using their arms or hands, a process called shaping. Melodic intonation therapy uses musical components. The person is first guided to sing what they want to say. So any communications are done via singing, and the patient gradually moves from singing to speaking. And finally, there's vocal music listening. This is the newest approach. This was first reported by researchers from Finland, published in the journal eNeuro in 2021. And what they found was that listening to vocal music improves language recovery. They had acute stroke patients who were divided into 3 groups. They listened to self-selected vocal music of the genre they liked. It could be pop, rock, country western, or self-selected instrumental music, or audiobooks for 1 hour a day for 2 months. 1 month later, they were examined. They were tested to see how good their speech was. They were also given a functional MRI of their brain. The vocal music group demonstrated significantly improved language skills that were correlated with improved axon pathways in the left frontal cerebral cortex. That is, they could talk better, and the brain showed improved connectivity compared to the other two groups. So that's the end of the talk. And there are two suggested readings. One I mentioned before in earlier talks, Stronger After Stroke. There's another book called Language and the Brain. Thank you very much.
Well, thank you very much, Bruce. That was an interesting chat. A lot of information there to take in, and I'm sure it will be of interest and use to all. I'm seeing Dr. A applauding. Thank you very much, and we are open to questions. I have some, which I will take by the way. But if anyone wants to speak up or put something in the chat, please do, and we'll take it up. Anil, you are muted. Maybe you can unmute yourself if you want to say something. Shruti, yes, please go ahead. You can unmute yourself and you can speak up. Shruti?
Yeah. Coming. Hi, Bruce. It's very nice to see you again. Hope you're doing well. In fact, I must say, after today's session, I have more doubts than before.
Yes. A lot of information there to take in. Yes, that is there.
I don't think I understood your question, but thank you for appreciating the talk. I'm glad I could participate.
Yes, yes. See, what I want to know is, in one of the slides, it was shown that the word repetition is altered. I was under the impression that a person who is able to speak words, who is not completely impaired of speech, will be able to repeat the word. But I saw that the word repetition is altered. So I want to know more about that. It means that the person's abilities after stroke depends purely on the centers of the brain which are injured. Am I right?
Well, the type of problem a person has after stroke depends on where the stroke occurs. And therapy has only been tested for people with Broca's aphasia. And the degree of Broca's aphasia will depend on how badly Broca's area is damaged. Sometimes it's a relatively minor aphasia. Sometimes they can only say a word or two, and that's it. There is one local patient in my stroke support group here in Wisconsin, and he could only say one word, and that word was yes. That's all he could say. But interestingly, one day we sang Happy Birthday to one of these stroke survivors, and he sang Happy Birthday fluently, because again, singing is controlled by the right hemisphere, and his stroke was in the left hemisphere.
Thank you.
Shruti, I was not very clear myself. You saw a slide on which what was mentioned? That there should not be many repetition. What was the query? If you can elaborate a bit for everyone.
Yeah, I was under the impression earlier that a person who is not having a very severe aphasia.
Yeah. So then,
I mean to say, my husband Guru Raj has very severe aphasia. Hello.
Yeah.
Well, again,
I thought word repetition was.
Remember, there are different types of aphasia. I assume you're talking about Broca's aphasia, where the person, where your husband cannot talk or talk well.
See, right now he is able to talk. improvement is there. But earlier I was under the impression that word repetition is possible by all those who are affected by aphasia. So after today's session, now I have learned that everybody is not able to repeat the words. Am I right?
Yeah, it depends. What I understood, it depends upon the damage. Some may be able to repeat, some may not be able to repeat. It all depends upon the damage to the brain and which areas of the brain. So in Broca's aphasia, just curious, Bruce, if you can elaborate upon that. In a case of Broca's aphasia, is it easy to repeat or is it difficult to repeat as against, let's say, Wernicke's aphasia, the two which are, the most common? What has been your experience, or what is your, readings tell you, Bruce?
I couldn't really. My speaker has got a lot of static in it, so I apologize for that.
What we were talking about, that suppose someone has Broca's aphasia, predominantly Broca's aphasia, will it be relatively easy for him to repeat different words as compared to someone who has another kind of aphasia, let's say Wernicke's aphasia?
Again, I've got so much static in my speaker, it's hard for me to understand. But remember that recovery from any type of aphasia is most pronounced in the first 2 or 3 months after the stroke. After that, it's very difficult. And remember, there are different types of aphasia, and recovery from Broca's aphasia is the only type that's been tested experimentally. And now listening to singing seems to help the most. And it's only been tested during the acute phase, but there would be no harm in trying in a later, more chronic phase. That is letting the person listen to records or CDs or whatever. That might help at any phase, but we don't know. It's only been tested during the early stage after a stroke.
Okay, but I think Shruti's experience would help us there. Because Shruti, I think in your husband, you're seeing improvement even after 3-4 years, correct?
Theoretically, you can improve from a stroke.
Definitely, yes.
Years,
yes.
Even 20 years after a stroke, you can improve. But that's only been tested on motor recovery. And I don't think it's been tested on speech recovery. But theoretically, your brain retains its neuroplasticity as long as you're alive.
Right.
So any recovery is possible.
Yeah. I will come back to you, Dr. Ray, but I just want to take Wilson because Wilson has raised his hand, and then I'll come to you, Dr. Ray. Wilson, you were raising your hand. What was that?
Yes, sir. I have a question basically for Mr. Bruce. As is explained that singing is quite helpful, or it will be imbibed very much better than speaking some particular words or some sentences. Yes, it is the problem what we actually face. I myself face when I have to say pin, I will say phone, or there is a confusion in some of my words. But how far, as far as this condition is concerned, how far singing will help me in improving my aphasia?
Singing should, yes. You can sing. Singing will help you learn to communicate. So Sing for your supper, as the
Okay.
song goes.
We all are bathroom singers.
Yes, right.
Don't worry. Sing
Indians
along.
are, I don't know about other parts of the world, but in the Indian houses, most of them are bathroom singers, but I don't know now. I myself had never been a bathroom singer, but yes,
But,
people do sing, and singing is better. That is what, of course, music and other therapy, or therapy in the sense, music is definitely, sometimes it is soothing to your ears, to your brain, and to all your completely spirit. Basically, it helps. Somewhere it is soothing. As far as words or speech is concerned. So I will definitely give some more weightage for singing also, and music as well. As far as words are concerned, words are definitely confusing. You need to get right words to speak rightly, and of course, I myself, being a lawyer, medical legal person, I find it sometimes very difficult, even reading medical terminology. It is a little bit, very difficult for me to remember certain words while making an arguments into the courts or something like that, because they are very much complicated sometimes. And of course, I will definitely think on this, think in the sense I will apply myself on this area of singing, and I'll try to improve how much it is going to help me out. I think so. It will definitely help me out.
See, Wilsonji, logically, I was just seeing the presentation also. Logically, kind of makes sense, because the melody is, as I understand, a different part of the brain, whereas, let's say, normal speech is a different part of the brain. So if hopefully the melody part of the brain is intact, that may be used to encourage speech, as Bruce also mentioned, start with melody and take it to normal speech, practice going to the normal speech. So it should, logically speaking, even going where some of the slides that we saw, the areas are different. So if one is damaged, maybe the other can be still used. That is what I feel. Yeah. Dr. Ray, you wanted to come in with something? Dr. Parth?
Yes, but I think there is another speaker, another participant hoping to say something. Ebenezer.
Ebenezer, if he wants to say something, yes. Ad, are you there? Maybe you can unmute yourself and say something. Ad, you have raised your hand. Can you, maybe you can come in?
Are you talking to me?
No, I'm talking to Ebenezer Adams, in case, because he had raised his hand. No, he is not, maybe he is not, cannot hear us now. So anyway, Dr. Ray, if you can come in at the moment.
Hello.
Okay, he's there. Yeah, Ad, you wanted to say something?
Yes. I do want to say something. First of all, let me commend the organizers for this webinar. Of course, it's very laudable, and it's an area that has been actually been left out. And I commend Prof for the insightful presentation that he has made. However, I will actually seek that the African Stroke Organization is a bigger platform where we have a lot of survivors, of course, persons, professionals working around aphasia. If going forward, we can actually collaborate, and of course, we will definitely have them join this webinar. Secondly, I would like to have Prof contact address that, of course, we can actually reach out to him to organize in collaboration with the Indian Stroke Support Group. We can organize such a similar area that is very, very important in the area of stroke, improving the lives of those with stroke across the globe. And my next question is, I want to find out, in communities where speech and language therapists are not available to actually render services to persons with aphasia, is there a mechanism maybe where those persons can actually access webinars, short training programs that, of course, they have actually come out with, which is very accessible to persons with aphasia, can actually go on and, of course, have them as a routine training program for themselves personally at homes? Is there anything of such nature that, of course, will be available for persons to actually access? This is my question.
Okay, I will address some of these, and then, of course, maybe Bruce or Dr. Ray can also come in. As certainly, and you are on our group, WhatsApp group also, and any possibilities you see, more than welcome of having a joint session to address not only aphasia, but any issues, common issues. So we do keep on putting links, and similarly, you can also put on, whatever sessions that you are having, please feel free. And maybe we can also talk off group of joint sessions. More than happy to work on that, and put together our resources, and whatever we can bring together to the platform. I'm sure we'll be more than happy. I think it is a great idea, and you are on the group also, and certainly we can talk about that. Coming specifically to
absolutely, thank you.
Yeah, coming specifically to aphasia related resources, I will firstly talk of India. Firstly, India is a diverse nation. Firstly, we have so many languages. English is not the only language. We have Hindi, again a predominant language. Unfortunately, most of the resources pertaining to aphasia that I see in India are, even as of now, English related, English based resources. We are trying to develop some pertaining to Hindi and encouraging that, at least to begin with, and maybe even later to other languages. But yes, that is a constraint, factor when we talk of India specifically. In the US, I do see off and on Facebook and other places, there are people having, Aphasia Cafe, for example, is one which comes to my mind. Some time ago, I had put a link on Facebook, on our group also, where they seem to be having regular sessions pertaining to, speech practice sessions specifically. Maybe Bruce has some more inputs on that. I don't know. Bruce, maybe you can come in here. Are you aware of aphasia practice sessions happening in the US? Which people.
No, I'm not really aware of that.
Yeah. Actually, there are not many, even in the US. Although I do, and I should develop more dialogue. I've been speaking to some of them. The National Aphasia Association is there. They're fairly active. Also, we have Tom Brossard has been coming to our sessions at a couple of times. Maybe we can speak to him. But again, to my mind, the issue will be two. One, of time. The time zones will differ. And the other issue could be of language, English only, but still we can make a beginning, certainly. So we can develop that line of thought. And again, I'm more than happy. Maybe you have speech language pathologists who can help us. We have some Sonal is on our group, although she does keep very busy. But whoever can come in, more than, I always keep on asking people, come in with your thoughts. Dr. Parth is here. He's been very helpful. Bruce, of course, has been very helpful. So do come in with your, and this is specifically to all the experts, do come in with your expertise. That is, we have whatever limitations we have within those, let us try to do our best. That's, all I can say. So does that address partly add what you wanted to bring in?
Yes, please. It does. It does. Thank you so much. I think what you said, I've taken it up. I'll touch base with you after this. Of course, we can have a lengthy discussion as to how we can take it from there.
Yeah, that would be great. That would be great. Dr.
Thank
Ray,
you.
coming to you, if you had something to add, Dr. Ray. You can unmute yourself, Dr. Ray. Yeah.
Yes, I tend to take up a lot of time when I start.
No, that's okay. We can give you some time now.
Okay, yeah. We kept the best for the last. Well, my first duty is to thank Professor Hetzler for a fascinating talk. I was taking notes, and I rarely take notes when I'm listening to patients' forums. But today I was, because I was learning, revising, and reminding myself and understanding a lot of the faciology concepts from those who I've heard before, and I didn't realize it was such a doyen in the linguistics world. And I just bought the book from Amazon that you suggested. Language.
Oh, really?
Yes.
Well, nice. Well, good.
Okay, great.
£1.49 plus postage and packing, a used version. And yes, I will read it. So that's very important. So thank you very much.
You're
wonderful.
You're very welcome. Thank you for taking notes. You'll pass the test when I give it.
Yes, I've been taking notes because I'm a neurologist, by the way. And
a neurologist?
I'm a neurologist, yeah.
Well, congratulations.
I'm a professor of neurology for India.
Oh, good.
Although I'm located in the UK for longer than I should.
Nice.
I would like to come in over here that whatsoever Mr. Bruce Hetzler has been explaining, it has been really into a very simple way, and it is understood by the layman as well. That is what I myself can feel, that I am learning something neurology, and that was really a very great experience. So I thank you once again that it is understandable very much to the layman. Thank you so much.
Indeed.
I'm glad you enjoyed it and learned something.
Yeah, we too enjoyed it. Yeah, please continue.
What Bruce was saying was very in-depth and was very cardinal and was very much classical neurology, explained in very simple terms, which Dr. Gaikwad take on board. And I will come to Dr. Gaikwad because you do medical legal work as well, which is very unusual in India, and that should develop because lawyers don't have much of an insight into the medical part of things. So that's another field. Let me our guest from Africa, because I'm a member of the African Stroke Organization as well. And I have a global link. Virtual medium, very generous people like Mr. Sodi, bringing us all together. We basically formed the core group, it seems, to spread the good news. The people far away in the villages of India are desperately in need of our input, and they should be the first who should be served. And I'm sure that applies to Georgia, Texas, and all areas outside New York City, Chicago. If you go out into the deep America, I think there's a great paucity of nurses and doctors. Not even discussing speech and language therapy. We'll come to that. Anyway, for our African colleague, I suggest to Mr. Modi that links established with the Indian Academy of Neurology and with the Neurological Rehabilitation Society of India, both of whom are headed by the president, and he will be able to provide the Indian inputs to our African brothers and sisters who have very little in way of neurological rehabilitation. It's our duty to hold our hands out to whoever in the world seeks India's help. It's our duty as Indians. So Indian Academy of Neurology and Neurological Rehabilitation Society of India are opening out their arms. I'm a member of both Prosody to establish contacts. Regards the applications, India is a bilingual, trilingual country. I speak 3 languages simply, and in the same sentence, I could be using 3 words from different languages. There are people who
I can hardly speak 1 language, so I'm impressed.
All right, not a problem. But most of my Indian patients are bilingual or trilingual. And when we will discuss the matter, if we have time, I will ask you the question about which language first and which is easier to recover first. Because Mr. Gaikwad mentioned about some words which he finds difficult to access. And that's an accession problem rather than a linguistic problem. Or maybe I will not be able to utter an architectural term or engineering term because it's not used to it. And after a stroke, accessing new words, new languages, because there are circuits in the brain. Anyway, for my African colleague, there are resources including application that including in the Indian languages, in Hindi, and also from southern India, from my who are very much into the aphasiology and therapeutics world, including the musical therapy. And apart from you, sir, Bruce, there's another very good speaker on music therapy, on whose I also took note. Very good that was. But he's from New York as well. So what I was trying to say is that there are applications, including in the Indian language, which rely on repetition of the same exercise, where there is a deficit of trained personnel power, like speech and language therapists, light stroke sufferers, because this is a dose effect, and if you have the same application app on a smartphone delivering the same service, then it does develop language quicker and cheaper, as well as more efficiently at times when there is a lack of human resource. Like you said, Hetzler, we tend to study the motor system, the power, much more easily because there are scales that analyze that. For speech, we do not have so many intervention, pre and post intervention devices. That's why speech has become less research as to the effects of intervention, be it constraint induced therapy or melodic therapy or whatever. So that's, I think, an impediment. Speech has not been given so much attention, but we are human beings to help speak to each other. If that's somehow affected by a disease, we will get it back. In neurodegenerative disease, it's difficult because the process continues. Stroke is a one-time insult. As long as you can get back up and running again, then it should be possible to recover a low. I heard a discussion about this 2.5-year time point, which you also mentioned. But I think this recovery process is lifelong. It's a dose effect. The longer we keep it, we could potentially try to recover a lot over time, but the effect needs to be sustained on rehabilitation. That's one of the points I hope to make. Now, I have a few questions for you, some science questions, Professor Hetzler. You mentioned about, first of all, about this multilingualism and bilingualism. I know you come from a country where there's only one language. So do you have Spanish-speaking people who you have studied? Hispanics, you see, Spanish-speaking people with English in America. What are your results on Spanish sufferers of stroke? If Spanish was their first language and then they learned, like English is not my first language. So,
yes, I do not know as far as language goes, I do not know how Broca's aphasia would affect bilingual people. I vaguely recall Broca's aphasia. And again, I don't remember exactly, but I think I recall research showing that people who use sign language being affected by Broca's aphasia also. But
It's
I
okay.
don't know about bilingual or trilingual people.
Our colleague Sonal, Miss Sonal Chitnis, who Mr. Sodi just mentioned, is one of our very enthusiastic leaders in the theology world. And she actually invites me to. And I'm so grateful. He, along with American collaborators, has been doing a lot of work on bilingual and multilingualism in children as well as in stroke sufferers. And there's a lot of research going on in that perspective. May I be a bit radical and now say that all these Brocas, Wernicke's, and Arcuate Fasciculus is basically old wine. There are new bottles in connectomes and MRI features and fMRI, which show that the rigid definition of Broca's area, Wernicke's area, left brain, right brain, is no longer as cast iron as Broca thought it was. Do you want to add to that on that concept of the new ideas about localization of aphasias and how these areas after stroke recovery phase, or shall I say something?
I'm not familiar with research on that. I couldn't answer that.
Okay, well, I'll try just for and if there's anybody else, because I'm not an aphasiologist, I'm just a neurologist. The classical teaching.
If I can just come in there, Dr. Pada. See, increasingly, and I was seeing somewhere very interesting documentaries on Netflix or maybe on Amazon on that, not specifically focused on aphasia per se, but generally speaking, the recuperating ability of the brain, where in fact, for example, the vision zone damaged, but an alternate zone, which perhaps at that time was not connected to vision per se, but developed sufficient ability to restore partially the vision of the affected. So there are, in fact, interesting discoveries there, developments there. Some of them are on YouTube also. And I think I did put it on our group. I will put it again, because I found it fascinating, how an area of the brain, perhaps not known to be connected with that function, takes over that function, consequent to training and retraining. So that is happening. I'll put again, find some more. As a layman, I'm saying, of course, but
more than a layman now. No. We have all been educated by Professor Hetzler, so none of us, 10 people remaining, are 10 people anymore. We know more than most neurologists about language now, thanks to our last 1 hour's talk.
Yeah, anyway, yeah, for sure. And that was Yep, you were saying, sir?
I was saying that this was a cue from the question Mrs. Gururaj asked about the time duration of the words. What Professor Hetzler mentioned to us was the classical way we have been taught about, and its localization from the original Tan who we talked about. Correct. That was beginnings of understanding of all this. But now that we've got MRI, fMRI, both, where we study which area of the brain light up with blood flow when one talks. In a stroke subject, or even in somebody who is bilingual or trilingual like me, when I speak in English, certainly a different part of the brain is being accessed compared to जब मैं हिंदी में बात करता हूँ, तुरंत दूसरा जगह में जाना ज़्यादा हो जाएगा. ये होना जरूरी है. Because when I speak in English, I'm accessing a different theme and phoneme, the small areas of words that I'm using to build up my language. लेकिन जब मैं दूसरा कोई मुहावरा बोलता हूँ, तब different association areas are coming up. আর আমি যখন আমার অন্য জায়গায় যাব, তখন বাংলাতে কথা বলার সঙ্গে হিন্দি में बात करने, when I come back to it, certainly the same areas of the brain are, and this is normal. That happens to everyone all the time. And now we have proven this by MRI studies, tract studies, and hence here now comes what Mr. Sodhi was saying, that even if you lose a part of your brain through a head injury or through a stroke is more defined, one part of the brain. Head injury is more, or infections and well, then you can always retrain other parts of the brain to develop those same functions. Maybe not as efficient as before, but certainly a lot more than what the nihilist would be encouraged to say. So I think it's very important to keep trying, like muscles. If you keep exercising a muscle, it has to build up. And you never give up. So I have a lot of hope, even 20 years down the line. And language is not only, we just discussed sign language, Mr. Sodhi said about gestures. That's also a language. If you want to come here, don't come. These are also languages. And we are actually written language, Alexia, Agraphia, Musia, music in the brain is a different center altogether. So we are talking only about spoken speech, written speech, but there is musical language, gestural language, mathematical language, and God knows how many other languages we have. Body language, again, that's again to be studied. Facial language, you mentioned about Prosopagnosia, which is the Angular Gyrus. And I was going to ask you, it has got an evolutionary role regards fear detection, because your fusiform gyrus connects straight to the limbic system where we hold our memories. Like babies look at the mother's faces or the father's faces and know that you get a sense of, somebody's looking at them in an angry way or loving way or emotional way. But face conveys a lot of emotion as well. And that's also into the language systems that we have. So this is fascinating, basically. And I'm so honored to be able to hear it because it's brought up so many themes. How did Oliver Sacks mistake his wife's for a hat? I didn't quite understand how he thought it was a hat, and only when the wife revolted, he found it was the wife's face and not the hat. How was that explained?
Well, again, this is Oliver Sacks, a famous neurologist who's since passed away. But he's got a book, The Man Who Mistook His Wife for a Hat, and that there are a number of clinical cases in that. One of them is that one. And he titled that because this man would reach out and grab his wife's hair and pull it as if he were trying to pick up a hat.
I don't understand it.
Now, presumably he had damage to the fusiform gyrus, but it was not explained that well in the article. The point, though, was that he could not recognize his wife by her face, but when she called out in pain, then he recognized her. He recognized her by her voice, but not by vision. That was the point of the article.
I see. Thank you. Because you said about some people not being able to identify somebody's voice because of prosody problems. And prosody is another problem in Parkinson's. Like you mentioned 3 ways. I'm going to the cinema. Am I going to the cinema? I'm going to the cinema. And you Top Gun's Maverick. You mentioned that was very good. Tom Cruise, I meant. Tom Cruise's Top Gun, released a week ago.
Yeah.
I shall stop here because I don't want to, But thank you, Professor Hetzler. It's been a pleasure listening to you.
Oh, you're most welcome. It's my pleasure. I'm happy to do this.
And thank you to my African colleagues. Thank you.
Well, again, I think we are almost well past 9, 1.5 hours. Thank you very much, Professor Bruce. It was indeed, as we said, and I also, simply explained presentation. Of course, there are developments on a continuous basis happening, which gives us a lot of hope and encouragement. And you provided a solid background grounding of what is happening so that we can take it further from there. So again, thank you very much for all your time. I really appreciate it. Thank you for all who could join in and their questions. And of course, we will take it up further. We'll come back to you again, Professor Bruce, for the stroke and sleep presentation. I also have that in mind. We'll take it up sometime in the future. So thank you very much again. Thank you for your time, Professor Bruce. And
you're most welcome. It's been my pleasure.
Thank you. It's always good to talk to you. Great. Thank you. And I'm closing the meeting now. Thank you very much, everyone.
Okay.
Take care.
Thank you.
Thank you.